Thank you very much to the North Texas chapter of the ACS for allowing me to speak with you again today. I would like to talk to you about the shifting attitudes in the use of imaging in the diagnosis of acute appendicitis in children. So pediatric appendicitis is one of the most common indications for surgery in a child. There are more than 70,000 appendectomies performed in children annually at a cost of just about $2/3 of $1 billion. In years past, it had been a purely clinical diagnosis based on history and physical examination alone. However, with the increasing availability and accuracy of imaging, and most notably CT scan, it's become increasingly a diagnosis either made by or confirmed by use of imaging. CT in particular has advantages in that it's fast, it's accurate, it's very portable. You can load your CD and send it out with your kid if you're transferring them somewhere else. Unfortunately, it also comes with a significant cost. It can represent a significant portion of the cost of the hospitalization for the child, but it also comes with it the risk of ionizing radiation. A single abdominal CT in a child is equivalent to approximately 250 chest x-rays and carries with it a 1 in 1,000 to 1 in 10,000 lifetime risk of a malignancy. At Children's, we perform roughly 800 to 1,000 appendectomies a year. Usually about 2/3 of the children present initially to Children's Medical Center, and about a third are transferred in from outside hospitals. Given the recent evidence about the risk of CT scanning in children, we've made a concerted effort to switch to ultrasonography as the first-line imaging study of choice. In a 4-year period, we were able to reduce our use of CT scan by half. Over the same time period, ultrasound pretty much completely supplanted CT scanning. With that in mind, we wanted to see if the practice patterns of our colleagues out in the community had changed similarly. So with that in mind, our aim was to compare the both type and frequency of imaging obtained at outside hospitals with that at Children's Medical Center, and also to compare the accuracy of imaging studies, namely CT and ultrasound. We performed a 1-year chart review. We made the decision to include only males because we wanted to basically control for potential confounding gynecologic diagnoses. We also chose to limit the age range in order to make sure that the children were of an age where they could actually tell us their own symptoms and their own history. We also excluded any children who underwent an interval appendectomy. This left us with an N of 385 patients. We collected data on the history and physical examination, the use of imaging, as well as the operative findings, namely negative appendectomy, non-perforated or perforated appendicitis. So as I mentioned, roughly a little bit less than 2/3 of children initially presented at Children's Medical Center of Dallas, and about a third presented at the outside hospital. Among children who presented at Children's, almost 90% had an ultrasound as their initial imaging study. Only 7% had a CT scan, and 7% of children went to the operating room without any imaging. Among children who went to an outside hospital initially and were transferred, approximately 2/3 had a CT scan, only 7% had an ultrasound, and 27% were transferred without any imaging whatsoever. So there's approximately a 1 in 10 ratio of use of ultrasound preferentially over CT at Children's, and slightly less than 1 in 10 ratio of CT used preferentially at the outside hospitals. Then we wanted to look at how accurate was ultrasonography at Children's, and we found that in 80% of patients it was diagnostic, and combined with the history and physical exam, that was sufficient to confirm the diagnosis and head to the operating room. Among the 20% in whom it was non-diagnostic, those children did go on to receive a CT for an overall use of CT of about 24%. Then we wanted to look at what happened to the children who were transferred. The imaging obtained at outside hospitals was overall very accurate. Very few children who had a CT went on to require any other imaging, and those who did had an ultrasound. Surprisingly, the ultrasounds performed at outside hospitals were also very accurate, with only about 20% of those patients needing additional imaging at Children's, which is actually an accuracy rate that's similar to what we had at Children's, although the N is a little bit low. And then among the children who were transferred without any imaging whatsoever, only 8% had a CT scan, 55% had an ultrasound, 15% needed both, and 9 children, or 22%, went to the operating room without any imaging. It's important to note that the ratio or the proportion of children who received each imaging study is almost identical to that of the children who initially presented to Children's. In our population of 385, there were no negative appendectomies, and there was a slightly higher rate of perforation among children who were transferred from an outside hospital, but that's still well within the range that's reported in the literature. So this slide kind of sums up overall use of imaging. And again, 7% of children at Children's Medical Center went to the operating room without any imaging. Only 9 out of the 40 who presented, or about 20-ish%, went to the operating room without any imaging among children transferred from outside hospitals, for an overall rate of only 7% of kids making it to the operating room without imaging. So in conclusion, we did find that there is a significant difference in the practice patterns at outside hospitals compared to Children's. There's about a 10-fold preferential use of ultrasound at Children's compared to outside hospitals. We did, however, find that CT and ultrasound are both very accurate. CT is more accurate, however, it also carries with it some risk. And with an ultrasound accuracy rate of about 80%, we were actually pretty happy with that. We believe that ultrasound is the preferred adjunct study for use in children with appendicitis. It was sensitive, it's less costly in terms of the monetary cost to the patient in the healthcare system, and it also eliminates the risk that's carried with ionizing radiation. We do believe that there is still a role for the use of CT scanning in the evaluation of appendicitis, particularly in children in whom an ultrasound is non-diagnostic, or there's concern about potential perforation, as CT scan findings could alter your plan of treatment. But really what we found is that there's been a really significant shift in the approach to appendicitis overall. What was formerly a purely clinical diagnosis has now become one based, or at least reinforced very strongly by imaging, as evidenced by the fact that only 7% of our children went to the operating room without any imaging study. Children's has made the effort to transition from CT scan to ultrasound, and we believe that based on how accurate the ultrasounds were at outside hospitals, there is probably a role for a larger use of ultrasound at outside hospitals as well, and that this represents a significant need for education among our colleagues in the community. Thank you very much for this opportunity.
I have 2 questions for you. First, congratulations on an excellent study. We all know that CTs are easier to read if people have a bit of body fat on them. There's more definition, more contrast, and ultrasounds are conversely more difficult. Since this is a retrospective study, do you think that could account, body size might have accounted for some of the selection bias in those that you did decide to CT ahead of ultrasound? Is the first question. And the second question, when I was a resident, we used to watch a lot of people, where you'd admit people and serially examine them. Even in adults now, I've pretty much gone away from this practice. I think a lot of my colleagues across the country have as well, and part of that is resource utilization and expediency. Do you see that as playing a role in the shift towards imaging in children as well?
So to address your first question, we did not specifically look at data regarding body mass index or body fat among these children. And I think, kind of answering both parts of your question, a significant number of the imaging studies were obtained actually before the surgeon had been consulted. And we're not exactly sure why that is. I think part of it is that there's a large impetus among ER physicians to get an accurate diagnosis, to kind of comfort the parents and say, this is what's wrong with your child and this is how we're going to treat it, and to get a rapid disposition for the patient. We have talked to our ER colleagues and asked them, when you're accepting a transfer for children who have suspected appendicitis, do you ask for any imaging study? And our ER colleagues say absolutely not. They prefer the child to be sent without imaging so that we can examine the child ideally and then decide, do we need any imaging? And if so, what to use? We also did not look at rate of children who were admitted for observation in serial abdominal exams, but that would be something to look at in the future.
Go ahead.
Greetings, Lottie Dallas. Nice presentation. Just a quick question. Are you planning on another study looking at girls?
Yeah, so there actually was, we have been planning on expanding our expanding our study to include kind of a broader population, including basically all age ranges and all both males and females. There was actually a recent study out of Washington University in St. Louis that did include all comers, including males and females, and their findings were almost identical to this, that there was a big discrepancy in the use of imaging at a children's facility versus at the outside hospitals, and again, an accuracy rate of ultrasound of about 80%, and that was in all comers.
Dr. Chen?
Erica, that was a nice presentation. Now that we have a protocol in our ER about who to image and how to image them, you might be able to get some cleaner data in the future and compare. My question for you is, you've looked at imaging within the population of those getting an appendectomy for appendicitis. The question that I have is really the universe of kids getting imaging are those with abdominal pain. And so do you have a sense of whether in that entire universe of abdominal pain kids, whether your incidence of CT scan and ultrasound is actually higher or lower? And if you have an answer for that, if you looked at that information, what you think we should do about it?
So we did not look specifically at kind of all comers to the ER with complaints of abdominal pain. I think it is a limitation of our study that we did limit to children who actually did end up going to the operating room for an appendectomy. To be honest, I don't have a sense of what the relative use of CT scan versus ultrasound is based on my own anecdotal experience. I think a lot of the children who don't have a history that sounds a lot like appendicitis do tend to get a CT scan as their first line imaging. But I think ultrasound would be an equally good choice for them as well, along with a plain film.
Go ahead.
Since you had to scan only CT scan only 4% of your population, or maybe pediatric population, do you think it's worthwhile to skip that step and go to surgery in only 4% of the patients where you don't have a solid diagnosis? And we don't know how many of those would not have appendectomies, and would that be worthwhile considering the risks and costs of CT scan?
So again, we limited our population to children who did undergo appendectomy, so I don't know the rate of children who had a scan and did not go on to have conservative management. I do think that there's probably a larger role for diagnosis based purely on physical exam and history alone. Previously a negative appendectomy rate of 5 or 10% was acceptable, but I think now in this culture that we have and the relationship that a lot of physicians have with their patients' families, it's really hard to tell your parents that, I'm pretty sure that this is the diagnosis, but I'm not 100% sure, and there's a chance that we could get in there and not find appendicitis. I think a lot of parents aren't necessarily willing to accept that, and they don't necessarily understand the risks that come with the CT scan, even if it brings certitude of diagnosis.
Thank you very much.
Thank you.